So now let's move to the next talk that is also regarding microvascular decompression. And the talk is about the efficacy and safety of microvascular decompression for trigeminal neuralgia in patients with morbid obesity. Dr. Aarón Giovanni Munguía-Rodríguez from Mexico as well. Please go ahead.
Thank you. Can you hear me? Can you see me?
Yes.
Okay. Good morning from Mexico. My name is Aarón Munguía. I'm going to present you efficacy and safety of microvascular decompression for trigeminal neuralgia in patients with morbid obesity. We are talking about trigeminal neuralgia. That is a chronic neuropathic pain disorder characterized by paroxysms of electric shock pain involving one or more divisions of the trigeminal nerve. Pain severity can hinder activities of daily living and impairs quality of life. The pharmacological therapy includes anticonvulsant medication that initially reduce the pain. However, the efficacy of the medication generally decreases over time and can cause important side effects. Microvascular decompression is the most effective treatment to achieve long-term pain relief of trigeminal neuralgia. Microvascular decompression is offered to young and healthy patients. Neurosurgeons tend to be reluctant to offer this surgery to elderly and obese patients due to the comorbidities that could cause complications during general anesthesia and posterior fossa surgery. Trigeminal neuralgia is a not life-threatening condition by itself. However, it can cause lifelong episodes of pain, becoming disabling. A quick and accurate diagnosis as well as a proper management can be beneficial for patients and lead to a better prognosis. No single studies of microvascular decompression have been done in patients with morbid obesity due to the small sample size and the refusal of some surgeons to operate on these patients. The aim of the study was to evaluate the safety and efficacy of microvascular decompression to treat trigeminal neuralgia in patients with morbid obesity. From February 2017 to October 2021, we attended 1,634 patients with hyperactive dysfunctional syndrome. We excluded patients with other neuropathies to only have patients with classical trigeminal neuralgia, of which the non-operated and those who received other types of procedures were also excluded. 589 surgeries were performed, of which only patients with normal weight and patients with class 3 obesity were included. Demographic characteristics of pain, comorbidities, pre, peri, intra, and post-operative data, as well as complication rates and outcomes were collected for each patient. We selected morbid obesity patients with the objective that the results were more contrasting. The diagnosis of trigeminal neuralgia is based on a clinical evaluation to identify unilateral facial pain associated with trigger points and characteristic paroxysmal and electric nature of pain. Routine MRI was performed in all patients to confirm the neurovascular conflict and rule out another entity. The surgical treatment should be offered only to patients who were refractory to medication, who refused to percutaneous procedures, or patients who received such treatments with unsatisfactory results, especially those whose quality of life is seriously compromised, regardless age and weight. Obese and morbidly obese patients require more medical care and monitoring before undergoing surgery. Prior to surgery, comorbidities will be controlled. It is recommended to eat healthy, mainly foods with fiber. Medications such as anticoagulants should be suspended. And especially it is recommended to perform exercise with an spirometer from 7 to 14 days before the surgery to improve lung capacity. The routine lab tests for all patients include blood count, blood chemistry, general urinalysis, and coagulation tests. For obese patients, studies of lipid, liver and thyroid profiles, as well as chest X-ray and electrocardiogram are added. Possible candidates for surgery are previously evaluated by the neurosurgeon, by an anesthesiologist, and by an internist. If any abnormality is detected that interferes with the operation or endangers the life of the patient is referred to the corresponding specialist and undergoes treatment until it is controlled and surgery is rescheduled. If control is not achieved, the patient is no longer a candidate for the surgery. All patients are informed about the risk of the procedure and sign a consent letter. The steps of the surgical technique are listed here, which is very similar between normal and obese patients. The main difference is the difficulty of position and intubate the obese patient. They require the placement of an endotracranial tube with metal core, central and urinary catheter, and anti-embolism stockings. The procedure also needs a skin incision of 5 to 7 centimeters. This is larger than a normal weight due to the adipose tissue. The procedure, at this moment, the surgery is carried out in the same way, always monitoring the stability of the patient. Another important point to highlight is to consider the prevalence of a high intracranial pressure in the obese patient that is reported before by our group. The results, we included 50 patients with normal weight and 26 grade 3 obesity with an average body mass index of 23 and 43 respectively. Female patients were more abundant in both groups. The right side was slightly more affected. The average age in both groups was similar, around 53 and 51 years. The duration of symptoms before the surgery was 7 and 9 years, with no significant difference between the two groups. The characteristics of pain were similar in both groups. Being the combination of branches B2 and B3, the most affected. The type of pain was mainly electrical. Most patients mentioned that pressure and movement were the main triggers of the pain. Patients present severe intensity at the time of the surgery. These results indicate that obesity does not influence the characteristics of pain. In the case of preoperative comorbidities, all obese patients had a higher number of comorbidities than normal weight patients, and they also presented with multiple comorbidities. Metabolic and cardiovascular comorbidities such as diabetes and hypertension were the most common in obese patients. Normal weight patients have a higher number of respiratory comorbidities, mainly by tobacco dependence. It might be thought that obese patients have consumed more medications. However, we found that the number of medication ingested was similar in both groups. Most of patients use carbamazepine. What we must highlight is that the dose of carbamazepine used was significantly higher in obese patients, possibly requiring higher doses due to the greater volume of distribution. Before anesthesia, we found that obese patients had higher degrees of ASA physical status classification and higher intubation difficulty scales. So anesthetic management of obese patients requires more attention and care. Regarding the times, the hospital stay and the duration of microsurgery did not show significant difference between groups, while the stay in the operating room and the anesthetic time, as well as the duration of surgery, were longer in the obese. More times mean the use of more medical supplies. Regarding the intraoperative findings, there were no significant difference between groups of patients. The contact mainly is arterial and single by the superior cerebellary artery. When it is a venous contact, the pontine veins are the main or the most frequent. These findings suggest that there are no obesity-related anatomical change in the neurovascular conflict. Post-operative complications are very diverse. However, the frequencies are very similar between both groups. It was only shown that the obese patients have more nausea in those of normal weight. Obesity does not seem to increase the risk of suffering more post-operative complications. However, the medical center must be prepared for any unexpected event. Microsurgical decompression reduces the pain in both groups in a similar way. So obesity does not appear to affect the efficacy of the surgery. In the most current follow-up, 48 patients present good results, excellent results, sorry. 20 had good results, 5 had persistence, and only 3 had recurrence. So far, our results suggest that obesity is not related to persistence or recurrence. However, more studies are still required. In the extra handling and the extra supplies to guarantee the safety of the obese patients generates an additional cost to the surgery of approximately 15%. Microvascular decompression should be considered in obese patients where is the only effective treatment to improve the quality of life. Safe and effective microsurgical surgery can be achieved with careful perioperative management. Thank you for your attention.
Thank you very much, Dr. Munguía-Rodríguez, for very nice presentation and just perfectly fitting in the program regarding the time of the presentation. Well, I don't know whether my co-chair, Professor Ramesner, wants to make any comment or any question.
Yeah. Thank you, Miguel. I think it's a very good talk, and I agree with your conclusions. The large number of cases is such an important condition that I remember when you were talking about the trigeminal neuralgia. I remember doing my fellowship with Professor Cano almost 20 years ago now, if I think about it. He said for a neurosurgeon, there are 2 stressful operations to say. One he said was the trigeminal neuralgia operation, and the other one he said was the elective unruptured aneurysm operation. I think the reason he said that, the reason for that was essentially they are normal patients, right? You're operating on a normal human being. And you're doing a big operation on these patients. So that makes you give some more stress. So I think that is true. And in terms of the position you mentioned, sometimes I feel lucky to be operating on head, because if you have an obese patient, we were lucky that the head doesn't get obese, so that you don't have to worry about, unlike spinal surgeons or general surgeons who have to deal with such morbid obese patients. So, but I think in terms of the position, my concept, my view would be in terms of a lateral position versus supine position would be the shape of the neck and how thin the neck is rather than the actual size of it. Because positioning laterally in an obese patient is quite difficult, and there are anesthetic issues, as you correctly pointed out. But and also, thank you for looking at the other implications of operating on these obese patients, because the cost is higher for them and they stay in hospital for a longer time. There are anesthetic issues and medical complications, including CSF leak, sort of increased incidence of CSF leak, which is a concern for many of these patients. And so I think that's what I have to mention about it. There's nothing else I would say. I can't really think of anything else. Anyone else want to make a comment? Can
I invite, if is it okay, Miguel, can I ask Dr. Aarón Giovanni whether do you have any comments? Dr. Gadol?
He might
yeah. Okay, that's okay. What do you call Prof. Grottenhuis? Do you have any comments, sir?
I just agree with Ramesh that, well, the position, it depends. I have to say that in obese patients, you're fully right that usually the general surgeons and our colleagues, the spine surgeons, have more difficulties in these patients. But nevertheless, the neck could be thick and could be sometimes there is hardly a neck. So in a supine position, turning the head, this is something I actually, even in the outpatient clinic with these patients, I already test that. I test also in elderly patients, I just test how far they can easily, without any complaints, move their neck. And that's because sometimes it is arthrosis, they can't do that. And if it is already a patient that is anesthetized and is in your operating room, you can more or less force anything, especially if you have a head clamp, skull clamp, and then you turn that head any way around. What I teach my residents is that they always have to look to the opposite jugular vein, that is kept free. And why I do it is lifting the mandible. The mandible, you lift it up before you start turning, so that the outflow is always free. That's the reason that I never let a resident operate who was not present during the positioning, because positioning is so essential. And in obese, it is even more. I mean, these patients are there, and if they have trigeminal neuralgia, we have to take care of them. But there it is a little bit more tricky. And I loved your study that you can show that at the end, there is not much more problems with them, higher cost. But I would think about thrombosis. I would think about CSF leak because, they press more. A venous compromise, that you would have more difficulty with cerebellar swelling or anything. It's great to see in the study that more or less, we don't care. This may be for us to start with when we finally are inside. Doesn't matter at all. So wonderful study. Congratulations.